next presenter. Our next presenter is Professor Dr. Shady Elia. I will call him, if he allow me, my colleague or my mentor. He approved to participate in our event willingly, entitled New Entities in the WHO of Soft Tissue and Bone Tumors. And we are so much delighted to have you with us, Dr. Shady. Please let me know if you can hear me.
Yes, Dr. Muhammad. Do you hear me?
Yes, I can hear you.
Yes. Actually, I'm very pleased and honored to be among you, and I want to thank my dear colleague, Dr. Muhammad, for allowing me to be among you today and to share this very interesting topic. I'm trying to share my screen. I don't know if you can see it.
Yes, we can see it now.
Okay. Okay. Today I will discuss with you for the next 20 minutes, I hope so, the new soft tissue tumors entities, and I will not speak about any bone tumors because the time is too limited. So I hope I will be able to cover as much as possible of the soft tissue tumors. The new entity, we have actually new additions on this last WHO, the 5th edition. Some tumors are totally new and others were previously there. Some have new names, and others were below other titles, and they are out because they are proved to be of different immunophenotype or different prognosis. We will speak about changes in adipocytic tumors like the atypical spindle cell pleomorphic lipomatous tumor, myxoid pleomorphic liposarcoma. We speak about 3 entities in the fibroblastic myofibroblastic tumors, which is the EWS1 SMAT3 positive fibroblastic tumor, angiofibroma of soft tissue, and superficial CD34 positive fibroblastic tumor. New additions to the vascular tumors, specifically the anastomosing hemangiomas, and new details were given for the tufted angioma, capuciform hemangioendothelioma, epithelioid hemangioma, especially the newly added types, the cellular and the atypical. Epithelioid hemangioendothelioma, we have 2 different gene fusions identified now, and the composite hemangioendotheliomas. For the smooth muscle tumors, we have the inflammatory leiomyosarcoma and the EBV-associated smooth muscle tumor that was previously mentioned by one of the presenters. Skeletal muscle tumors, spindle cell sclerosing variant, which have 3 different subtypes now, the congenital, the MYD1 mutant, and the intraosseous one, and it was mentioned also. The peripheral nerve sheath tumors, we have the malignant melanotic nerve sheath tumor and the ANOOB, and then we will end by the NTRK rearranged spindle cell neoplasms. This is what's new in mostly bone tumors, but we will not discuss it. Let's start with the adipocytic tumors. The atypical spindle cell pleomorphic lipomatous tumor, it is actually it's a benign adipocytic neoplasm. It was given several names before. First, the spindle cell liposarcoma, and now you can see that it's benign. It occurs predominantly in the middle-aged adults, but it can affect any age. Predominantly in the hand, foot, and thigh, but it can arise anywhere. It has two main features, which is the ill-defined tumor margins, and then features the specific histological features. To make things simple, a typical spindle cell pleomorphic lipomatous tumor actually is a spindle cell lipoma with the features that you know about spindle cell lipoma, the myxoid background, scattered adipocytes, ropey type collagen, and moreover, you can have univacuolated or multivacuolated lipoblasts or some bizarre pleomorphic multinucleated cells that are usually different from what you see in the pleomorphic lipoma. The pleomorphic lipoma, you can see multinucleated cells, which are called floret cells. They are tripolar or trilobed cells, but here these are kind of bizarre cells. We can see some heterologous elements like the smooth muscle, cartilage, or bone. Let's go to the morphology. Here you can see relatively hypocellular tumor with a myxoid background, adipocytes. Some are in the form of univacuolated lipoblasts, like here. This is a hyperchromatic nucleus with a univacuolated lipoblaст. So the main difference between the spindle cell lipoma and the atypical spindle cell pleomorphic lipomatous tumor is the presence of hyperchromatic spindle cells, hyperchromatic lipoblasts, or bizarre cells. For the cellularity, there is a big spectrum starting from the low cellularity spectrum, which we will call a typical spindle cell lipoma, which is usually seen in the hands and feet. See here, you can see the atypical cells here. And on the other spectrum, a high cellularity spectrum, which we call fibrosarcoma-like lipomatous neoplasm, which is markedly cellular, but with other areas that can show typical features of a typical spindle cell lipoma. Immunohistochemistry, wise they are maybe CD34 positive. We all know that the spindle cell lipoma are all CD34 positive, but here there is variable expression together with the S100 protein and the desmin, and mostly they are MDM2 and CDK4 negative, because the main differential diagnosis when you see a typical nuclei in a background of adipocytic tumor, the first thing that will pop up in your mind is maybe this is a well-differentiated liposarcoma. So you have to perform the MDM2 and the CDK4 together. For a well-differentiated liposarcoma, both will be mostly positive. But in this tumor, you might have some weak focal expression of one of them, but rarely both. Molecularly, there is no MDM2 amplification, and there is loss of nuclear RB1 expression. Let's move to the second one, is the myxoid pleomorphic liposarcoma. We are all aware of the myxoid liposarcoma, which is formed of bland-looking rounded and oval cells within a myxoid background that show chicken wire thin-walled vascular plexus. And the high-grade counterpart of the myxoid liposarcoma is when it harbors round cell elements or a lot of round cell elements. But this is a bit different. Why? Because it shows pleomorphic cells. It is not acceptable to give a diagnosis of myxoid liposarcoma with when you have pleomorphic cells. So this is why we got this entity. It's usually seen in children and adolescents. The location, it has a predilection to the mediastinum, but it can present elsewhere. Histologically, as I previously mentioned, you have areas that look like conventional myxoid liposarcoma with the relatively bland looking oval or round cells. That and in some areas you will start to see the pleomorphic cells scattered within these hypocellular areas, and there is a transition to a more cellular area with markedly pleomorphic cells. Sometimes you can see also bizarre looking lipoblasts in these cellular areas. Immunohistochemically, there is no specific markers. We know all that for the myxoid liposarcoma, we have the DDIT3, which is a specific marker for this entity, but here DDIT3 is totally negative. Together with the MDM2 also is negative. This is the morphology. On the left side, you can see here a myxoid background with chicken wire vascular pattern with the bland looking grounded cells, but here we can start to appreciate larger hyperchromatic cells, which is not usually accepted to be seen in myxoid liposarcoma. And by time you will appreciate more and more atypical bizarre looking cells, and maybe at the end of the spectrum of cellularity you'll see markedly cellular areas. Let's move to the fibroblastic, myofibroblast tumors. The superficial CD34 positive fibroblastic tumor is a tumor that was described back in the 2013. It has a distinctive low-grade behavior, but morphologically it looks ugly. It looks as if it was a high-grade thing. It usually presents in middle-aged adults. Clinically, it is typically slowly growing, painless mass in the superficial soft tissues, like in the deep dermis and the subcutaneous tissue of the lower extremities, especially thigh, arm, buttock, and shoulder. And as you see here, that the locations here are in the proximal side of the limbs, because there is a very important differential diagnosis here, which is usually seen at the distal part of the limb, which is the myxo-inflammatory fibroblastic sarcoma. And the morphology of this tumor will show why this is an important differential diagnosis, because the superficial CD34 positive fibroblastic tumor can show very large bizarre cells with eosinophilic cytoplasm and intranuclear and intracytoplasmic inclusions, which kind of look like the large cells of the myxo-inflammatory fibroblastic sarcoma, but the myxo-inflammatory fibroblastic sarcoma show a very prominent eosinophilic nucleolus, which we call virocyte-like nucleolus, which is not present here. As I told you, it's a superficial tumor in dermis and the subcutis, circumscribed, but it can have infiltration or infiltrative part in the adipose tissue. It's mostly highly cellular, formed of spindle and epithelioid cells having abundant eosinophilic cytoplasm. So by low power, it is an red tumor, although it shows pleomorphic cells, but it is a red tumor by low power because of the abundant eosinophilic cytoplasm. The neoplastic cells show marked nuclear pleomorphisms as previously seen in the picture with bizarre nuclei. The main feature that makes you think about this diagnosis, that you have an ugly looking tumor but almost with no mitosis. So an ugly looking tumor with no mitosis in the superficial part. So you have to think about the superficial CD34 positive fibroblastic tumor. And by immuno, you will appreciate the CD34 diffuse strong expression together with the focal cytokeratin expression in 70% of the cases. This is a low power. This is, it's kind of reddish tumor in the deep dermis. And by high power, you can see these markedly pleomorphic cells, and sometimes you have this inflammatory infiltrate in the background, which might let you think about the myxo-inflammatory lymphoblasttic sarcoma. Another new entity is the angiofibroma of soft tissue. This is a totally benign tumor, usually seen in middle-aged adults, also in the extremities, mostly around large joints, like the knee, but it can be seen elsewhere, like the abdominal cavity, the back, the pelvis, and the breast. Once you see a single case of angiofibroma, you will never forget it. This is the typical features of angiofibroma of soft tissue. You can see the marked vascularity in the form of thin-walled, like chicken wire vascular pattern, which reminds me of the myxoid liposarcoma. But the difference here between this tumor and myxoid liposarcoma is that the tumor cells here are like spindle with a bit tapered nuclei, together with beside the myxoid areas you can have collagenous areas like this. This picture shows part of the tumor with a myxoid background and part of the tumor with a collagenous background, with the uniform arrangement of the vascular plexus, which is seen all over the tumor, uniformly arranged. Another thing to take care of is you can see medium-sized or ectatic blood vessels with variably thick walls, sometimes hyalinosed walls, and this feature is also seen in solitary fibrous tumor. So you have to take care and not to misinterpret this type of vascularity as a hemangioparasitic pattern. It's different from the hemangioparasitic pattern. Immunohistochemistry, it variably expressed CD34, EMA, SMA, and Desmond, but definitely it's negative for STAT6, which is specific for solitary fibrous tumor. Molecularly, you can detect the gene rearrangement, which is usually seen in this tumor, which is AHRR and NCOA2 gene rearrangement. Another emerging tumor, but it's important to mention because it's seen mostly in the hands and feet, and it shows histologically a zonation pattern with a central hyalinosed area and a peripheral cellular area. Once you see a tumor with central eosinophilic material, maybe hyalinosis, maybe something else with cellular rim, you have to think in the hands and the feet about the epithelioid sarcoma. And epithelioid sarcoma can show spindle cell morphology also. So this is an important differential diagnosis. So this is why we have to know this entity. But here, the epithelioid sarcoma has a center of mostly necrosis, fibrinoid necrosis, but here it's just hyalinosis, not necrosis. So the zonation pattern is very important here in the hands and the feet. The peripheral areas are cellular and consist of bland-looking fascicles of uniform spindle cells that can infiltrate the surrounding fat or tissue, and can show also some calcification with the differential diagnosis of calcifying aponeurotic fibroma, definitely in this area. This is the morphology. Here, this is an intermediate power with central hyalinosis in this area and cellular features here in the periphery. This is a higher power on the cellular area, which looks like very bland spindle cells. And at the periphery, you can show this kind of invasion in the surrounding fat. What makes this tumor easily to recognize is that it shows ERG immunohistochemistry expression. All of these tumors show this marker. If we don't have the luxury of doing the molecular studies, so a tumor that is superficial with specific specific zonation, central hinosis, peripheral bland-looking spindle cells infiltrating the surrounding tissue with ERG expression, but other vascular markers are negative. So this suggests EWSR1 SMAD3 positive fibroblastic tumor. Let's move to the smooth muscle tumors, EBV-associated smooth muscle tumor. This is a very interesting tumor because it is strictly associated with Epstein-Barr virus. So usually it's in a setting of immunosuppression, like AIDS, patients with organ transplantation, or in children with congenital or primary immunodeficiency disorders. It can occur anywhere, but mostly deeply, so deep in the visceral organs. So this is the first tumor that we don't mention, that it is in the extremities. It's deep in the visceral organs, either GIT, liver, lung, spleen, maybe brain, especially in AIDS cases. These tumors are often multicentric, and they don't think in multicentric tumors that it's kind of metastasis. No, they are original tumors in each location because they detected different viruses. They are Epstein-Barr, but they have different features from each tumor. The age is according to the cause. The prognosis is favorable. They usually do not metastasize, so it's important to recognize them and not to call them sarcomas. Histologically, they look like any smooth muscle tumor, but they have a specific feature, which is the presence of more primitive appearing round cells. Here, this is an ABV-associated smooth muscle tumor. This area looks like any smooth muscle tumor, but you can appreciate foci with high cellularity showing primitive looking round and oval cells. And the diagnosis is made when you perform the EBER, which is the in situ hybridization for Epstein-Barr virus. For immunohistochemistry, it's usually positive for the muscle markers, the usual muscle markers, but the diagnostic marker is the EBER by ISH. Inflammatory leiomyosarcoma, it was there before, but was under the title of leiomyosarcoma, but because these tumors are usually low grade and usually have better prognosis than the leiomyosarcoma, they are now out and they're given a specific given as a specific entity. It's usually in the lower limb, at the trunk and the retroperitoneum. It's worth mentioning that it's important to know this tumor because an inflammatory sarcoma in the retroperitoneum, you would think about a dedifferentiated liposarcoma. But this is another tumor that can be seen in the retroperitoneum. Histologically, this tumor usually is infiltrated by immune cells, and the type of immune cells are mostly lymphocytes and histiocytes. We all know that the inflammatory infiltrate in the dedifferentiated liposarcoma is mostly neutrophils. You can see any type of immune cells, but mostly neutrophils. In the inflammatory myofibroblastic tumor, it's mostly plasma cells, but here most cases show lymphocytes and histiocytes and maybe foam cells too. Some mammoth calcification can be seen. Immunohistochemically, it shows the muscle markers as any leiomyosarcoma. Molecularly, the near haplodization is an important pathogenetic characteristic, and the outcome is favorable. This is the morphology of this tumor, cellular, showing lymphocytic infiltration, and these are the tumor cells. You can see that the number of immune cells outnumber the tumor cells. Here we can see that there are a lot of foamy histiocytes. By immuno, there is a pitfall here that most of these tumors expected to be Desmond positive, but they can be MYOD1 positive too, so they can be mistaken as rhabdomyosarcoma. So take care about this pitfall. And this is the 163, which highlights the histiocytes. One entity was described, which is the histiocyte-rich rhabdomyoblastic tumor. It was not added in the WHO, but actually it shows great similarity to this entity, so maybe they are the same entity, but it's not clear till now. Malignant melanotic nerve sheath tumor, which was previously called melanotic schwannoma. The name was changed because all these tumors behave in a malignant fashion, so it's not appropriate to call them schwannoma anymore. It's a rare aggressive peripheral nerve sheath tumor composed of Schwann cells, showing melanocytic differentiation, and sometimes it shows also samoma bodies. Location, mostly it's around the spine. It arises from the spinal or autonomic nerves near the midline. So this is the main area affected by this tumor, but it can present in other areas. Histologically, it doesn't look like schwannoma, but they're atypical spindle cells and epithelioid cells. They are all Schwann cells, but they look different than Schwann cells that we know in schwannoma. A lot of pseudo-inclusions, eosinophilic nucleoli, which we usually see in melanoma. We can see melanin pigments, and this is the main differential diagnosis, melanoma here. They diffusely express S100, SOX10, and other melanocytic markers, but they have specific molecular mutation in PRKAR1A. 50% of them are associated with corneal complex. This is the morphology: spindle cells and epithelioid cells with a lot of some melanin pigmentation and some calcification here. ANOOP, which is the atypical neurofibromatous neoplasm of uncertain biological potential. This was newly added under the title of neurofibroma. This term was proposed specifically for patients with neurofibromatosis type 1, but it's not applied to the sporadic lesions. This diagnosis is given when you have at least 2 of the following 4 histological features in a neurofibroma: cytologic atypia, loss of neurofibroma architecture, hypercellularity, mitotic rate, which is more than 1 per 50 hyperfields, but less than 3 per 10 hyperfields, because if you have more than 3 mitoses, this is a low-grade malignant tumor. This is a morphology of neurofibroma. This is a usual neurofibroma with the myxotic collagen arrangement, which we call shredded carrot appearance. This is a cellular neurofibroma, but it does not show any fascicular arrangement, just the cells with intervening collagen also. So this is what we call the normal neurofibroma pattern. If you have this pattern, this is a neurofibroma. If you have a lost pattern, that if you don't see this, so it might be changing. Here, this is an ANOOP. On the left side, we have a typical neurofibroma morphology, but here in this area, the neurofibroma pattern disappears, and it's replaced by a spindle cell proliferation arranged in fascicles here. So this is what we call loss of neurofibroma pattern. If you find this together with atypia, like this one, this is an atypical nucleus. So this is an anoob together with the mitosis and the cellularity. Lastly, in our presentation, a tumor which is an emerging entity in the tumors of uncertain differentiation, which are the anti-RK arranged spindle cell neoplasm. These tumors, beside the infantile fibrosarcoma, because it showed this rearrangement too, they represent an emerging group of molecularly defined rare soft tissue tumors with a wide spectrum of morphologies. Most of these tumors co-express S100 and CD34, and take care that S100 and CD34 are co-expressed in neurofibromas also, as previously mentioned by our one of our colleagues. The provisional category includes the recently described lipofibromatosis-like neural tumors and tumors that closely resemble peripheral nerve sheath tumor. Usually they present in children and young adults. They can be superficial or deep in the extremities or trunk, or anywhere in the body, to be honest. Histologically, there is a wide morphologic spectrum, but most of the tumors are low grade with monomorphic spindle cell morphology. So when you have a low grade spindle cell tumor with monomorphic spindle cell morphology and it expresses both S100 and CD34 with negative SOX10, so it is not neural. So please think about this entity, the anti-RK rearranged spindle cell neoplasm, because these tumors have a specific treatment, which are the anti-RK inhibitors. Molecularly, you will find the anti-RK fusion, definitely. Another important histologic feature is the keloid-like stromal collagen and the perivascular hyalinization, which is seen in a subset of cases. This is the morphology of this tumor: bland tumor cells, oval and spindle, with this thick collagen. Here you can see that it's infiltrating the fat, co-expressing CD34 and S100 together with the Pentrac antibody. The prognosis of this tumor is according to the histological features. If you have high-grade features, which is not common, so it will behave in a bad way. If you have low-grade features, it will behave in a good way. The good thing is that the bad tumors, if given the anti-RK inhibitors, there is a marvelous response to treatment. Thank you very much. Sorry for taking more time than allowed, but actually the entities are a lot, and I wanted to be clear in each entity. Thank you very much.
Thank you very much, Dr. Shady, and we are pleased to have you with us, and hope it is again and again, all the time, repeated times, inshallah.
Thank you.
And I will have a promise from you for the new entities in the WHO of the bone tumors, inshallah, in a recent presentation.
Inshallah.
Okay, doctor.